I'm the ICU director at San Gorgonio Memorial Hospital, so I'm in charge of the intensive care services. I've been with Beaver Medical Group as the pulmonologist, critical care specialist, and sleep specialist since 2007. I'm an assistant professor at Loma Linda University, and I'm also an assistant professor over at UCR School of Medicine. What is the biggest thing that I see in my sleep practice that can impede not only your ability to sleep, but also your partner's ability to sleep, husband and wife? That is obstructive sleep apnea. I think that's why a lot of you are here today, to talk about sleep apnea. So let's talk about that. There was an article that was published in The Lancet by a guy by Broadbent, where he describes a patient in his office and at home. Basically, he says here, the snoring ceased at regular intervals and the pause was so long as to excite attention and indeed alarm. How many of you have noticed this in your bedroom, either in yourself or in your partner? There's been a lot of press about this recently. Snoring can kill. You look at the wife waking up and she's seeing a skeleton next to her in bed here, okay? Discover how sleep apnea can be ruining your life. Here's a book. I love this. Exclusive, Actually Hear Deadly Snoring. So this is, there's a lot of hype about this, and probably to some detriment because people say, oh, it's a bunch of hype about people wanting to make money off of some illness. I can tell you that there is some serious consequences for sleep apnea. There's no question about it. And this slide really shows the problem. The problem is really up here in the throat. And you can see here that air is going in both through the nose and the mouth, but the tongue, which is situated right here, can sometimes fall back, or even worse, other problems, and it's going to obstruct the ability for air to get down into your lungs. And so what happens is your brain is divided into two parts. There's the brain stem, which is always working, okay? It's kind of like, maybe you're too old to know The Simpsons. Remember The Simpsons? Remember Homer Simpson would go and he'd work at the nuclear power plant. He was the guy in charge of the safety and had all the buttons. Okay, so that's what's going on down here at the back. Homer Simpson is down here in the back of your brain, and he's watching the oxygen and he's watching all of these things and making sure that they're all going fine. The upper part of the brain is what's functioning when you're awake. Okay? So when you go to sleep, the top part of your brain goes to sleep. And when the top part of your brain goes to sleep, the muscles in your neck also go to sleep. So instead of being a rigid PVC pipe, they're flaccid and they're collapsible. So when you take a breath of air in through your lungs, because the lungs got the sensation to breathe from Homer Simpson, who's regulating your respirations, if this collapses, no air is going to get in. Even though your lungs want to get air in, there's no air that's going to get down there. Okay? Question. If I wore oxygen, would that help? No, because no air is getting in. Even if I had 100% oxygen, no air is getting in. Okay? So that's the issue. So what happens when no air gets in? Your oxygen levels start to go down and down. And what happens? Little red light, you die, yeah. No, because Homer Simpson is not asleep. He's in the back of your brain and he sees the oxygen level going down, right? So then what he does is he grabs the broomstick and he takes it and he knocks on the ceiling up above, and he wakes the guy up here in the top part of the brain that your oxygen's going down. So what does the top part of the brain have to do? It has to arouse out of its sleep in some fashion. Maybe not completely awake, but in enough fashion that it sends the nerve down to the neck muscles to open up and allow that air to go in. So it might sound like this. You're breathing normally, and then you obstruct. And then there's silence. Then Homer sends a signal down. Does that sound, how many have you heard that before? Okay. So what happens? The oxygen level goes down. Homer Simpson knocks up above. The guy upstairs wakes up enough to send the signal down, opens up again, oxygen comes back into the lungs, and oxygen level comes back up again. And then what happens when the oxygen level comes back up again? Homer Simpson's happy. Guy up above is happy. Everyone goes back to sleep. Cycle begins again. And this happens maybe 100 times an hour, maybe 50 times an hour, 30 times an hour. It depends on how many times an hour will determine how serious it is. And so what you have is this oxygen level going down and this oxygen level coming up. And every time this cycle occurs, guess what's released from your adrenal glands? Adrenaline. Adrenaline is released from your adrenal glands. And what effect does adrenaline have on your vasculature? It's not good. Increases the risk of stroke, increases the risk of heart attack, congestive heart failure, hypertension, all of these things. Okay? And so they have done the studies and have associated all of these things with sleep apnea. And if you treat the sleep apnea, the risk of these things goes down. That's where the real drive is here, okay? Is to reduce coronary events. Now, that's the coronary event consequence. What about your brain? How would you sleep if somebody was sitting next to your bed hitting a gong every minute? You wouldn't sleep so well, would you? That's essentially what's going on. Homer Simpson is waking you up every hour, okay? How many times an hour? We don't know. We'd have to do a sleep study to find out. So again, here's the problem. This is going back. It's causing obstruction. Obstruction. Now, see the tongue right there? Guess what, guys? When you gain weight, you, more than women do, especially premenopausal women, tend to store the fat in that tongue. So not only is the airway getting smaller, but the thing inside the airway is getting bigger. That's not good. That's going to increase your risks of having obstruction. The converse to that is, guys, when you lose weight, you lose it faster from the tongue as well. So not to say that weight loss is the end-all for the treatment of sleep apnea, because you can have people as skinny as a rail and still have sleep apnea. Nevertheless, the tongue is a big problem, and that's why you'll see these dental devices, and we'll talk a little bit about that. Okay, so this is the definition. At least one patient complains of unintentional sleep episodes during wakefulness, daytime sleepiness, unrefreshing sleep. Patient wakes up breath holding, gasping, or choking. Bed partner reports loud snoring, breathing interruptions, or both during patient's sleep. It feels like you're being suffocated. This is from Aliens, okay? You guys remember that movie back in the 80s? Oh, never mind. Actually, it was the 90s. So you have to have a sleep study to figure if this is actually going on. What do we need to know? It's obstructive sleep apnea. We need to know if you're asleep. That's why we put wires on your head. We have to know if you're breathing. That's why we have a little thing on your nose. And we have to know if you're breathing here. Okay, so we have a little strap around your waist. Does he look happy to be there? No. No. Okay. The good news is that we're finding ways of doing this at home without all the wires. They're called home sleep tests, and that's the new wave. So you don't have to sleep in a sleep lab. But this is the kind of data that we get. And I'll step you through this a little bit here. This is what I do every night. I get downloaded three or four sleep studies after somebody sleeps in the lab, and they send it to me. And after I put my kids to bed, I'm exposing my eyes to bright light, and I'm going to bed later and later. Nevertheless, I am reading these sleep studies to see if we have the evidence of sleep apnea. Now, this is a French sleep study, so everything's in French, but I'll notice this. This is compressed data, and you can see here, do you see this wave here? That's your oxygen level going up and down, up and down. And you see this here? This is the movement of your chest. And the movement of the chest becomes muted here. And there's a little bit of a delayed response, so not much movement in the chest causes a decrease in the oxygen. Finally, what happens? These are brain waves. Can you see what happened right here? Finally, there's an arousal. That's Homer Simpson waking up the top part of your brain. That's what you should be doing. Well, that's not actually even good sleep there, but that's what sleep looks like. This is what being awake looks like. Can you see the difference? Those are brain waves. Pretty cool, huh? I can tell all that, and obviously this patient has severe sleep apnea. This is what's going on every night. They're being strangled to death. Okay? So what's the treatment? The treatment is, this is a mechanical problem. And a mechanical problem, I think, should have a mechanical solution. If the problem is like a flat tire, if your airway is like a flat tire, and air cannot move through a flat tire, then the treatment would be to pump up that tire and have it remain open so that air can move back and forth. And so that is the purpose of that. So if we can inflate the tire, inflate a flat tire again, using some sort of pressure system to keep that airway open while you are sleeping, then we can avoid the obstruction. And that's exactly what CPAP is for. Now, CPAP stands for continuous positive airway pressure. That's exactly what we're talking about. You understand now why that would work. It's because we're trying to put an airway of pressure in there just enough to stem that airway open so that it won't collapse. Okay? CPAP is the oldest treatment for sleep apnea. It is the most studied and it is the most effective. Okay? Any other treatment for sleep apnea is because someone doesn't tolerate CPAP. The compliance rate is about 60 to 70%. That's a significant amount of people that can't tolerate CPAP. So, but in terms of its efficacy, we can titrate it so that it's perfect and that you don't have any sleep apneas. So there's different types of masks. There's ones that fit over the full face, that includes the nose and the mouth. We always must include the nose, okay? So nose and mouth. Then there's ones that fit over just the nose. These work really well if people are good at keeping their mouth closed, okay? So we ask them, do they gossip a lot? If they gossip a lot, we go to the, no, I'm just kidding. So physically, they've got to be able to keep their mouth closed. And obviously, you know the reason why, right? Because you can't pump up a tire if there's 2 holes in it, and only one of them is patched. So if we put air in through the nose and it comes right out the mouth, it's not going to go down here where it's needed. So sometimes we'll actually give them a chin strap. Here's some other examples. This is called the nasal pillows. So instead of fitting over the nose and causing maybe an abrasion on the nose over long-term wear, it actually fits into the nose and we can anchor it on the tooth, on the teeth or on the face. Okay, those are nasal pillows. So sometimes we need to use a chin strap to keep the mouth closed. And you can see here are some examples of that. Here's what CPAP machines look like. Some of you have newer ones. This is kind of an older one. Almost all CPAP machines, in fact, I would say all of them now come with heated humidification. That is just a necessity because not having humidification makes things very uncomfortable, and you'll improve compliance if you have heated humidification. In terms of how loud they are, you know, I'm worried about this CPAP machine. It's so loud. They're becoming softer and softer and quieter. They now range around 26 to 30 decibels. Okay, that's half that of the buzz of a mosquito. Here's a sleep study from overnight. What we typically do is we do a split night study. So we split the night into 2 groups. Now check this out. Here we're looking at their oxygen saturation. What does that look like? That looks like the San Andreas Fault because it's going up and down, up and down. Each one of those Homer Simpson wake-ups is one spike. Can you see how many times they're getting up and waking up? They don't even realize that that's happening. It's all happening subconsciously. And we mark each one of these episodes with a little line down here. You can see there's so many lines that they're just running together. These are OSAs and these are hypopneas. So this is where they completely stop breathing and this is where they almost completely stop breathing. And you can see here there's stages of sleep. Remember that graph I showed you at the very beginning showing where they are sleeping? And so you can see here that here they're sleeping, they go to bed, arousal, and then they wake up. Now we put them on CPAP. And notice we start out at a pretty low level. So we started off at the lowest level possible and we just have them sleep with that. And through the night, there's a respiratory tech there that's watching them. Okay, I know how hard is it to go to sleep when there's someone watching you, right? They're actually watching you in the back room, and they're not really watching you, they're watching the data that's coming through. And they see, well, we've gotten rid of a lot of the apneas, but there's still a few of these hypopneas, which are almost stop breathing. Let's continue to ramp up the pressure. And the goal here is to ramp up the pressure enough so that we eliminate the apneas. And that's exactly what we do. Finally get to a final pressure before the end of the night. Notice that they went into REM sleep here. Here at this REM sleep, notice something that's really interesting here. Here's the REM sleep, right? Notice what happened when they went into REM sleep. They had a few more apneas. So the pressure was not enough. That's why we keep going up on the pressure. Finally, we get up to a pressure where they go into REM sleep and they have no more desaturations. There's 1 or 2 little ones there, but that's okay. You can have up to 5 an hour and still be normal. This is what's going on every day of this person's life. This is what their new life is going to look like on CPAP. Here's another example, and another example. There, we went right to 10. Look at that REM sleep. Sometimes they get out of there and they're like, wow, I have never slept like that. And I have some patients that would shoot me if I told them they had to go on CPAP. And I have some patients that would shoot me if I took away their CPAP, because they just will not live without it. So here's what we call, in terms of the apnea-hypopnea index. I don't want to get too much into the details, but obviously the more times you stop breathing, the more severe it is. In terms of men, about 24% of them have an AHI of 5 per hour. That means that they stop breathing 5 times every hour. You can stop breathing up to 5 times an hour, and that's normal. That's okay. Women is about 9%, but let me tell you, women catch up to men very quickly after menopause. Okay? They catch up. So this is not a male-only disease. And we notice that HRT reduces the risk, but let me tell you, HRT is not great, because what does hormone replacement therapy also do? It increases the risk of stroke independently. Okay? Risk factors, obesity. You know, if you lose weight, your AHI goes down. Your risk of sleep apnea goes down. Also race. Non-whites typically have a higher incidence of sleep apnea, because it's not only weight, but it's also facial structure and nose and palate. And some of those things are genetic. You know, if you have a first-degree relative who has sleep apnea, that increases your risk substantially. So there's genetics that are involved as well. Nasal obstruction as well. Age. As you increase in age, up to the age of 65, it increases. After the age of 65, we see the prevalence just sort of plateau. We don't know if that's because those people are just dropping off the face of the earth, but it seems to plateau. Maybe it's kind of, I don't know, survival of the fittest. Interestingly, hypothyroidism doesn't seem to have a connection, and menopause is known as the great equalizer for women in terms of sleep apnea. So what happens if you don't wear it? So what are the consequences of obstructive sleep apnea? We talked about this. Daytime sleepiness, neurocognitive functioning. So where did I leave the keys? I can't think straight, I can't concentrate. That's because you can't sleep, right? Okay, so you got to be able to sleep. Mood disorders, depression, decreased quality of life, hypertension, diabetes, stroke, cardiovascular, motor vehicle accidents. All of these things can be associated with sleep apnea. So CPAP therapy, as I said, it's first-line therapy for OSA, reduces blood pressure by 10 millimeters on average, improves or resolves daytime sleepiness, does great. Compliance we talked about, 5 to 7 nights per week for about 4.5 hours is deemed as compliance. We talked about humidification, working on the right fit. Other things that you can do, weight loss, even a 10% reduction. Check your BMI. Have your BMI measured. Okay? If you don't know how to calculate it, there's calculators online. If your BMI is over 25, you should lose weight, and you might notice an improvement. If you don't solve your obstructive sleep apnea problem, you may reduce the pressure that is necessary to treat it. Okay? All right. Smoking can cause inflammation in the airways, and that's just going to shrink that area more. Alcohol reduction. Okay, so alcohol. What is alcohol's effect on sleep apnea? If you think about giving Homer Simpson a drink of alcohol, that's exactly what it's going to do. The guy who's looking out for you, who's watching your oxygen, if he's not on the job, that oxygen level is going to go down for longer, and you're going to have a more delayed recovery. So alcohol is not good therapy, and this also goes along with sleeping pills with sleep apnea, okay? Because it's your bottom of the brain job, the responsibility of that to wake you up. And if it's under the influence of Ambien or these sleeping pills, that's not a good thing. So non-CPAP therapy, oral appliances, There's two types. There's the jaw advancers, and then there's the tongue suckers, okay? So you've seen these type of things. What's the purpose of this? The purpose of this is to advance the jaw forward, and because the tongue is anchored to the bottom of the jaw, if I can advance the jaw forward, then I can advance the tongue forward. The whole point of this is to advance the tongue off the back of your throat, okay? That's the whole purpose of this. The problem is that if you don't have all your teeth, you can't do it. Okay, the nice thing is that this is a lot easier to tolerate than CPAP in some cases. So in some cases we would go with this. It doesn't work so well for people with very severe sleep apnea. Okay, and also it can cause TMJ problems. That's the biggest problem for that. And then when you wake up in the morning, sometimes you feel like, let me chew some gum to get my jaw back into place. Okay, it's also a lot easier to carry this on a plane than a CPAP machine. So there's advantages and disadvantages. I think this is another tool in the tool shed for the job that needs to be done. Be careful of some of these boil and bite things that you get on the internet. Okay? They don't fit the teeth very well, and they really don't work as well. So just be careful of that. I would go see a dentist who's trained in sleep medicine if you're going to get one of these things. This is a tongue sucker. Okay? So you stick your tongue in there, and it sucks onto it, and then these little things right here, you pull it out, and you stick it on, so it locks onto the outside. So basically it grabs your tongue and pulls it forward, okay? Some other things. There are some evidence that this works. Notice here that our goal in CPAP is to get your AHI less than 5, because 5 is normal. What they find in these devices is that they can't get the AHI down as low. So 1 for 1, the CPAP is more effective than the dental device. CPAP more effective than the dental device. Their argument, when I say their argument, the dentist's argument is, well, these are actually a lot more easier to tolerate, so our compliance rates are better. So population-wise, it may be the same efficacious, but on a per-patient situation, if I can get you to wear a CPAP machine rather than a dental device, I think I can do a better job at getting your AHI back to normal. Does that make sense? Okay. Some of the surgeries, this thing called a UPPP used to be very, very popular 10 or 15 years ago. The ear, nose, and throat surgeons were basically cutting that little punching bag at the back of your throat out, and the soft part of your palate back there, they were opening that up, thinking that that was the problem. Ever chew something and swallow it and have it come out your nose? It doesn't happen because you've got the soft palate there. Sometimes that happens when you don't have the soft palate. And once the surgeon takes that soft palate out, it ain't coming back. So, yeah, this sometimes works. Didn't work as well as we thought it would. There are other things that we can do. There's implants. There's bariatric surgery to lose weight. There's even like irradiating the back of your throat to reduce the amount of tissue back there. None of this has really worked well. There's medications. Modafinil is a medicine that's not really for sleep apnea. It's for people who have excessive sleepiness despite the fact that their sleep apnea has been treated. And this kind of wakes you up a little bit in the morning, but it's by prescription. So, summary. OSA is a danger lurking in each bedroom. It's like a shark. Diagnosis rests on the overnight study. CPAP is the first-line choice. However, now the FDA has actually approved dental devices as first-line therapy in mild and moderate sleep apnea. What does that mean? That means you no longer have to show for the FDA that you failed CPAP therapy to go right to a dental device. Okay? So that is new. Behavioral changes, use of oral appliances, digging into the details in patients, and that's what a whole clinic visit is for. Otherwise, we could just, put the whole planet on CPAP, right? So actually talking to people, figuring out what their problems are, why they can't tolerate things, and tailoring the therapy for that individual is really where the key is, and education is key. I talk a little bit about CPAP. I equate obstructive sleep apnea and CPAP to, this is OSA, okay? You're in your stateroom. The ship is going down, and you have a choice. You either stay on the ship, or you go into your little dinghy boat here called CPAP. Or you could stay in the stateroom where there's no CPAP. Okay. There's other options now. There's many different types of lifeboats. And I want to thank you at this point and open the floor to any questions. Yes?
After having a sleep study and being diagnosed with apnea and being put on a CPAP machine, is it then advantageous to have a second sleep study to determine if your CPAP machine is working for you?
Good question. So what we want to have is we want to have data, material, sleep study that shows that you on the pressure that you are on eliminates the apneas. And that can happen in a number of ways now, at this point. It may not have been when you had it, but this is the way we can do it. We can have it where we do a split night study that we talked about before, and it showed that the CPAP was going up. So that would show that you, on that pressure, eliminated your apneas. So that's one way of doing it. So it's possible that if you had a split night study where they put the CPAP machine on you for that study and then you left, someone reviewed that data, said that you on this CPAP level eliminated your sleep apnea, then you do not need to have another study unless you changed your weight by more than 10%, or there's been a change in your clinical symptoms, or there's been a change anatomically.
So are you saying that an initial sleep apnea test actually used a CPAP?
There's two ways. Sometimes you can have a sleep test where they never got to the CPAP portion. And if that's the case, then what they would need to do is they would need to do another test. And there's a couple of different ways of doing it now. So the way that it used to be is you would have to go back into the same lab. They would then use the whole night dedicated to just putting a CPAP machine on you and adjusting it so they saw they got the right pressure. There are two other ways of doing it. The other way of doing it is doing something called an auto CPAP machine. And if they do an auto CPAP machine, they would never need to do another study. And let me explain what that is. A regular CPAP machine, you have to dial in the number, and it stays at that number. An auto CPAP machine actually can tell when you're having obstructions and will automatically increase its own pressure on its own. And so what that does is, let's say that your sleep apnea is worse when you're on your back, and it's not so bad when you're on your side. So if you're wearing the machine and you're sleeping on your side, maybe the sleep apnea machine checks that and says, oh, I only need to be at a pressure of 5. And then let's say you move on your back and says, whoa, and it ramps it up to 10. So it's thinking during the night for you, depending on the position that you're in. For that, we'll never need to have to do a study, because if we give you an auto CPAP, it's going to adjust itself 100% of the time. So in that situation, what insurance companies have done is they're willing to pay the higher price for the auto CPAP machine, which obviously costs more money than a regular CPAP machine. And they'll do that because they don't have to pay for another study. Does that make sense?
Yeah, I understand perfectly what you said. What I don't know is how to go about finding out what I need to do.
Go to your primary care physician and have him refer you to a sleep specialist if he can't figure it out, and have him pull up the old study. If that study was a PSG only, then you've never had data that shows you on CPAP. If it's a split night study, which means that they did CPAP at the end of it, then they should have that data. If it's been more than 5 years old, or you've changed weight, or you've noticed, then you may just need to have another titration. They call it a titration.
Is it advantageous to wear your CPAP machine if you're napping in the afternoon?
Absolutely. Anytime you're asleep, you should be on a CPAP machine.